Thanks for inviting me out to kind of go over hypertension. This has kind of been a love of mine for the last few years. We've actually been doing some research. We've had a randomized controlled trial that we completed this year at Methodist Women's. We're hoping to present at an international meeting for the Society of Maternal-Fetal Medicine in February. We find out at the end of October if we get that. Whether we do or don't, we'll probably be publishing early next year that trial. So we're hoping that that'll get some yardage out of it. So just kind of going through updates in hypertension today. So our objectives today, just to talk about changes in maternal mortality in the U.S., identify areas for improvement. Shocker, we're going to focus on hypertension. Analyze recently published studies, determine best practices, discuss implementation of best practices, how this may impact patient care. And I'll delve into a little bit kind of how I personally manage things and how I personally approach things. I think that's one of the things that doesn't ever come out in papers or guidelines is they give you all these things you should do, but they don't ever actually tell you how to do it yourself. And so I'll try to go through a few of the things that I pay attention to when I'm doing it and what I do. My wife and I went to Africa for our 25th wedding anniversary, so you're going to have to suffer through some images of some animals she took. So one of the things I always kind of start with whenever we do quality improvement is I give this little slide about quality improvement. One of the things you're taught when you go through med school and go through training is this is as smart as you'll ever be. You'll never be better than you are today when you finish and you take your exams. And I think that's an unfortunate way or an unfortunate thing to teach people because it kind of gets you away from the fact that we all should be lifelong students. And a lot of times the people who sit in the corner of the room and say, I don't like this, I'm not going to change what I do, their perspective or the reason that they're so adamant about it is the way that they've been doing it is the right way to do it and the way they've been doing it the safest. And if I tell them a different way to do it or we teach a different way to do something or talk about something, it implies that we weren't doing the best we could beforehand. Quality improvement is not about what you did being bad previously. What it's about is that learning a better way or a safer way to do something and changing how you're doing and evolving with healthcare to provide better care for our patients. So it's not an indictment of us. It's an encouragement to keep doing better. So the most recent maternal mortality data puts us about 2 times worse than the next closest developed country. 17.4 per 100,000 live births compared to 8.7 in France, on down to less than 2 in Norway and New Zealand. 2018 CDC data, around 17 and change. So now everyone is really adamant about figuring out the maternal mortality rate. What's the actual maternal mortality rate? Because it's all based on death certificate data. It's all based on ICD-10 codes and hospital backside coding and things like that. And so if anyone's ever worked with that data to try and do any research or do any work with it, it's actually very terrible data. So people took this information in a recent study in March and tried to break it down to look at what actually are our rates for maternal mortality. And because based on the CDC, we're at 33 right now, which is absolutely, I mean, we're on par with developing countries. So they took it, they broke it down, and they looked at the pregnancy boxes on death certificates. Turned out some of the women weren't even pregnant, but they were then counted towards our maternal mortality, and started delving into some of these. And what essentially they learned is that it's garbage in, garbage out. Our current rates don't mean a whole lot, but what's happened is with all these concerns, the states have all developed morbidity mortality review committees. For the most part, I think we're close to every state having one now. Nebraska's had one for about 8 years now. I am fortunate that I get to be a part of that, and they're all doing great work. And now what we're doing is delving into individual patient charts for every maternal death and starting to learn what is causing these deaths and getting accurate data about what the deaths are. And it's really interesting how the data is all evolving. But so when we break down maternal mortality by age and race, we're finding that as women get older, their maternal mortalities are rising. And as we look at their mortalities over the years, they've risen for every age group. And when you look at ethnicities, they've risen every time we've looked at those mortalities over the years, regardless of ethnicity. Everyone's mortality has gone up. So we're seeing this incremental rise in every age group and every ethnicity over the years. So when we start breaking it down by cause, these are what we see. And so recently, some mental health conditions really hadn't been included in the maternal mortality until 3 or 4 years ago, when the CDC started to include maternal mortality related to mental health conditions. and looking at suicides, that immediately leapt to the top of being the primary cause for maternal mortality. As you go down the list, the rest are kind of the classic things we talk about: hemorrhage, cardiac disease, infection, embolism, cardiomyopathy, those things. So kind of the next step is, well, where do we have room for improvement? Well, when the MMRCs sit down and look at these cases, depending on what states publish the data, the rates are running anywhere from mid-70s to 95% of maternal deaths are preventable when we look at pregnancy-related deaths. But there's some point in that process where there was an intervention that could have changed the outcome for that mom. This is a Cape buffalo getting his nose cleaned by a orange-billed oxpecker. We just thought it was fun that he was smiling at us. So when we look at the primary medical cause of maternal mortality, I think it's actually different than this slide. So when you look at this slide, hemorrhage is number one from a medical condition, not a mental health condition. Cardiac's number two, not far behind. Then you have infection, embolism, cardiomyopathy. Hypertensive disorders of pregnancy is way down there at 2, 3, 4, 5, 6, 7. So one of the things we do in the MMRC is we do a chain of risks. So when we look at these disorders and we break them down of where was the first place you could have intervened, when you look at moms who have cardiac and coronary events, when you look at moms who have cardiomyopathy, when you look at moms who have stroke, it turns out the common thread for 90-95% of those moms, when you back up, it's all hypertension. So what's happening right now, and literally as we speak, like last meeting for our MMRC for the state, they started talking about, we had a meeting at the CDC in April this year, and they said, really what we want you to do when you're coding these is look at your chain of risk and go back to your first disorder in the chain that you think you could have intervened to prevent an outcome. So if a mom has a cerebral aneurysm, dies from a stroke, that's a stroke. If a mom comes in and she delivers with severe preeclampsia and then has a seizure, has a stroke related to her seizure, dies related to her stroke, it's preeclampsia as her underlying cause of death. So that we can start to target the core of what's causing these maternal deaths and not treating the last step in the outcome. Because some of these things, there's no room for intervention. If we talk about, a mom dying from cardiomyopathy, if you've got a patient who rolls in 4 months postpartum with a 15% EF, there's not much you can do about that. But if she was severely hypertensive for 6 months before she got an EF of 15%, you could have intervened, you could have fixed that link in the chain, and you could have prevented her death. So what we're learning is when we back up and look at the core of these issues, up to 30% of maternal deaths are related to hypertension. So again, looking at cardiac conditions, cardiomyopathy, hypertensive disorders, cerebrovascular accident down there at 3%, you start adding these up and we're getting up to way more than we ever thought were related to maternal death. And there was some evidence that came out of California even before we started having state MMRCs. Back in 2002, 2006, they looked at their cause of death for 257 deaths. When you start circling it, the way it pans out, 43% of their maternal deaths in their state were all related to cardiovascular disease. So hypertension has been a quiet killer of women and fairly unrecognized killer over the years. Now, we spend lots of time seeing these women during pregnancies. If you've got a mom who's had a history of heart surgery or heart disease, chronic hypertension, we start seeing them at 20, we start seeing them every 4 weeks for growth. We see them at 30 weeks weekly until they deliver, make sure mom and baby are safe, and then baby comes out and we're like, all right, congratulations, you're great, go home, you're fine. The problem is when you start looking at maternal deaths, over 60% of them happen after they go home. So when we talk about preventing maternal death, we've done a great job of preventing maternal death during pregnancy. But for a long time, my opinion is we've neglected that fourth stage of labor, some people call it, of the postpartum course, where moms go home. And one of the places that this hit home for me the most was in residency. We had a mom who had Eisenmenger syndrome, which is pulmonary hypertension. So she had high blood pressure in her lungs, almost a universally fatal disease in pregnant women. And we admitted this mom at like 18 weeks of pregnancy, managed her throughout her pregnancy, got her to like 34 weeks pregnant, delivered her, got her to like 4 days postpartum and discharged her because she was postpartum. She's fine now. Her 8-year-old found her dead 2 weeks later. And so I started looking at when the deaths occur in Eisenmenger syndrome and pulmonary hypertension, and less than 10% of them happen during pregnancy. They don't happen while moms get pregnant because they slowly adapt, they get used to pregnancy, and then it's the postpartum shifts that kill them. And it's the same for hypertension. It's the same for lots of other diseases we see in pregnancy. During pregnancy, most moms do fine. It's after they deliver, when we send them home and don't see them as often, they get sick and they die. So the data we have now is that 60 to 70% of maternal deaths are postpartum from hypertension. Up a wildebeest on a beautiful morning. So in terms of updates on how we manage hypertension, I'm going to back up and start with during pregnancy, the CHAP trial, and will be our first stop. And then we'll talk about acute management of hypertension when those moms who come in intrapartum or during pregnancy and they come in with those severe inch blood pressures. And then we'll talk about improving that mortality in those postpartum moms and the management of pregnancy-related hypertension. So CHAP trial, has everyone heard about this in some way, shape, or form? Show of hands, head nod. So really well done, randomized controlled trial. They took moms prior to 24 weeks and said, if you have hypertension, we're going to get you back to normal blood pressure. The old teaching when I went through training was that if you get moms down to too low of blood pressure, the uterus and the baby are used to a high blood pressure, you're going to cause a small baby, you're going to make the baby sick, you're going to make mom sick, you're going to make a pregnancy worse. And so we always let moms kind of float in the 140s, 150s. That was our goal. And so these moms would be chronically hypertensive. So they compared moms who reached normal tension compared to moms who remained mildly hypertensive. And then essentially what they found was there was a lower incidence of preeclampsia preterm birth, in-some growth restriction, which was really kind of the sneaky underlying goal of the study. Serious maternal or neonatal complications were not statistically significant. There was a trend towards growth restriction in the arm that was more aggressively treated. And the relative risk for maternal neonatal complications was lower in the intervention or treatment arm. So essentially, if the study had gotten a little bit bigger, they included a few more people, they would have shown that there was nothing but benefit from being under better control with your hypertension while you're pregnant, which goes a little bit against the whole uterine perfusion theory. So that was a little countercurrent. And so this has resulted in a little bit of a change in thought process on how we manage these women. So the take home is this is for patients with chronic hypertension identified prior to pregnancy or identified during pregnancy prior to 20 weeks. That's a big key take home for what we do because a lot of our patients don't see doctors in between their pregnancies. The only time they get healthcare is when they're pregnant. So when you're looking back at those prenatals and she had a 140 over 75 when she was 12 weeks and then another 150 over 60 or something when she was at 18 weeks, those moms we label chronic hypertensives and then manage them as chronic hypertensives during their pregnancy. Treatment of blood pressure and normal tension beginning in the first and second trimester reduces the risk of obstetric outcomes for both mother and fetus. So this is becoming the standard of care for chronic hypertension. This is all caps because I am yelling. This does not apply to gestational hypertension, preeclampsia, or superimposed preeclampsia. Taking a mom who comes in acutely hypertensive and getting her down to 120 over 80 is not the recommendation. It's not the recommendation that she be managed outpatient on blood pressure medication. The recommendation from ACOG is that if a patient requires blood pressure medication due to pregnancy-related high blood pressure, that she be managed as an inpatient. So whether you think she has gestational hypertension, mild or severe preeclampsia, if you think she needs to be on meds, that her pressures are that severe, then she should be managed inpatient. So the other thing I kind of touched on was that the inclusion criteria is people be earlier than 24 weeks. So if you have a mom who is a late transfer of care, she's been chronic hypertensive, she's 32 weeks pregnant, you don't necessarily have to start meeting the CHAP criteria at that point because the study doesn't tell us how babies do if you start changing blood pressures at 30, 32, 34 weeks and getting them normotensive when they've been hypertensive the whole pregnancy. So the whole uterine perfusion theory, we definitely have disproven up to 24 weeks, but there's not any data beyond 24 weeks. So there's not a wrong way to manage those patients. If you want to leave them mildly hypertensive, I would agree that that's completely appropriate. If you want to get them to a high normal blood pressure, get them in the 120s, 130s, I think that's also reasonable. But we don't necessarily have data to support that management. So this is generally how I manage my recommendations for a chronic hypertensive: growth every 4 weeks after their anatomy ultrasound, BPPs at 32 to 34 weeks, depending on the severity of their hypertension and other comorbidities. If they have a BMI over 40, if they have diabetes, other issues, a lot of times we'll move those dates up. Delivery at 37 to 39 weeks, depending on their blood pressure control. 162 milligrams of aspirin. This should start as early as possible, 12 to 16 weeks, and we continue this until 30 weeks, 36 weeks. If they've been hypertensive for more than 5 years, I recommend an EKG. A lot of times when they have comorbidities, I screen all these patients for obstructive sleep apnea. So I ask them if they have daytime fatigue, do you snore at night, all those things. Do you fall asleep when you're watching TV? Do you feel tired when you're driving home from work and falling asleep at the wheel? It doesn't apply to people who are on call. I have obstructive job apnea.
Yeah.
So if they screen positive, I send those moms for an EKG and for maternal echo once I get their EKG, because that puts them at high risk for hypertension. Also puts them at high risk for pulmonary hypertension, which can be a major pregnancy complication. A baseline CBC, CMP, 24-hour urine. I've seen a trend towards people doing P-to-Cs in the first trimester. The reality is that P-to-C is no different than a urine dip. The ACOG guidelines are that if you have access to the resources to perform a 24-hour urine, you should perform a 24-hour urine. So if you have that patient who works even harder than all of us do, and she just does not have the time to do a 24-hour urine, you can have a P-to-C on the chart as your baseline. But really, if they have any proteinuria on that P-to-C or on that urine dip, I would send a 24-hour urine off to quantitate how much it is. If she does a urine dip or a P-to-C and it's negative, then that's great. You can just count her as having no proteinuria to start the pregnancy. And then if she has proteinuria later on, then that can represent your change for superimposed disease. Brother and sister. You don't realize how big their teeth and their mouths are until they yawn in front of you. All right, so management of acute hypertension. This has been one that we've all been working on and implementing the last 5 to 10 years. This is the ACOG bulletin, all in small print for first-line therapies. They still list labetalol first, hydralazine second, and oral nifedipine third. This is a pet peeve of mine. There is nothing but phenomenal evidence that nifedipine is the first-line agent and should be the first-line agent. And the old guard at ACOG has just not moved on yet. And so we can't get the guidelines updated to be best management right now. But oral nifedipine works faster than labetalol. You have less hypotension. You have fewer fetal side effects. We'll get to that in a minute. I'm already on my soapbox. I haven't changed slides yet. So which agent's best? So there's at least 5 studies down below there. These are all randomized controlled trials that are showing equivalency to labetalol or benefit from nifedipine. You have improved renal function in addition to quicker blood pressure control. And then we'll see when we get into the postpartum management, there's overlap with postpartum management. The nifedipine is a better medication as well. So the summary of all those studies is that nifedipine requires fewer treatments to obtain control. You have more rapid control, lower risk of clinically significant side effects, fetal distress, hypotension. And the only time I've ever seen hypotension with nifedipine was when a second agent was used. So mom got 3 or 4 doses of nifedipine, and then they gave her like 40 of IV labetalol, and her pressures just went through the tank. So
Do you then max them out on nifedipine before you switch? Or?
So I'm a vote of maxing agents before switching.
Okay.
Because one of the things I think is that some of these agents are synergistic when you change modalities. And so if you start down one road and then suddenly switch modalities, you might have a patient who's way more sensitive than you normally would think they would be. And I've seen it happen both ways. I've seen plenty of patients, I've gotten to 240 milligrams of IV labetalol and the patient hasn't budged. And I give her 20 of oral nifedipine and her pressures drop like a rock. Mm-hmm. And so that second agent, sometimes we have that urgency to get that blood pressure to control faster now because at that point, you're probably 4 hours into it, to be honest. I mean, you've probably given her 4 or 5 doses of a medicine. And so if you're doing doses of medicines every 30, 40 minutes, you're a couple hours into this, you want to get under control. So I see a lot of people skip the lower doses of the second agent and start higher. And that's when I see a lot of hypotension and problems from the second agent. So my personal perspective is to max out the first agent and then start your second agent and start back at the beginning and work your way up on the second agent. Rather than kind of like, sometimes it feels like a dartboard, like a patient will get 10 of nifedipine and then 40 of nifedipine and then 20 of labetalol and then 80 of labetalol and then back to 80 of nifedipine. And I'm like, we have no idea what's working and what's not working. So I like a standard approach to things. I think it helps organize the care. It makes it more predictable for the nurses. And I think you can better predict what the patient responded to, and you can better predict complications related to what they responded to. So, so this is our protocol to accomplish this. And I think this is what you guys have implemented as well, essentially. So we have a system where the nurses can give the first dose of nifedipine without physician order. It's a standing order. And then the goal of that first dose of nifedipine, and one of the things I try to teach is that the goal of that first dose is so that the nurse never has to wait for a physician to give an order or get a call back. The goal is not to circumvent the physician and not have to have the physician involved. That first dose gives you 20, 30 minutes to get a hold of a physician, get them involved, and get your ongoing orders for management of the hypertension. The goal, I have some nurses who enjoy the independence they get with having that order, and so then they keep giving 10 milligrams of oral nifedipine without calling the provider for additional orders. And so I've seen patients who've had their blood pressures managed for 4 or 6 hours using this, and they never got started on MEG, and they never got labs ordered or other things like that. And so one of the things I like to kind of drive home is the goal of that order is for the nurses to get the patient treated quickly to meet our NPEC goals of less than an hour from the time of diagnosis, and then buy them enough time to get the standing orders from the physician, communicate with the physician, and get the rest of the patient's plan established. So it's not meant to serve as an ongoing management tool. It's meant to buy safe time, because like at Women's, we have physicians from multiple groups. It's often difficult to figure out who's on call for who. And so sometimes it'll take our nurses 30 minutes to an hour to figure out who they're supposed to be talking to and to get a phone call back from them. So this gives them a tool to safely manage the patient until they can hear back from their providers. So again, back to expert opinion. So to get to your questions, this is how I usually manage things. I usually will manage with acute treatments for 6 to 12 hours to see how much medication they need. And essentially, if they need less than 60 milligrams in that 6 to 12 hour period, I'll put them on 30 of long-acting BID, even if they're still in labor. If they need more than that 60 milligrams of rapid-acting nifedipine, then I'll put them on 60 nifedipine BID once their blood pressures are controlled. And I'll start the long-acting nifedipine even when their blood pressures are back to normal tension. So if she's 120 over 80s and it's 8 p.m., a lot of times I'll give them that first dose of nifedipine to get them on that 8 p.m., 8 a.m. schedule, and not wait for their blood pressure to come back up to give them their long-acting med. I'll use that long-acting to bridge me and keep their blood pressure under control. And then labetalol is my second agent. So rapid treatment of this hypertension, this is an NPEC quality measure, the identification of severe hypertension to treatment in less than 60 minutes. The reality is you need 2 blood pressures 15 minutes apart, but the timer starts with the first one. So NPEC's not very nice to you. You get 45 minutes to treat that patient. And so that's why having the systems like we have in place helps us reach that goal. Women's, we're doing pretty well. I think we're in the 95 to 100% range every quarter for treatment. We have a few times where providers, for whatever reason, have chosen that they don't want the patient to be treated. So we're working on education, working on making things safer.
I put those numbers in and we're pretty much at 100%. The only fallout we had was one of my questions. If you have a patient that is chronically hypertensive and is supposed to be on a long acting and hadn't taken their morning dose and they come in and they're hypertensive, do you start treating with a nifedipine or do you give them their oral dose that they should have been taking previously? I feel like there's a lot of confusion sometimes on how we should manage that piece. I don't know.
Gestational age would be important in that scenario, because if she's 16 weeks,
right,
I'd probably have her take her long-acting medication to go home. If she's 38 weeks, I'd probably admit her. I would acutely treat her and see how she responds. Because if she's, gosh, I mean, to be honest, if she's almost past 24 weeks, for me, that buys her a hospitalization until you figure out if this is superimposed disease or if this is her just skipping her meds. And because the downside is she's like, oh, I skipped my meds this morning. But coincidentally, she's 36 weeks and she's also sick now. And she goes home or she's at home skipping her meds all the time. I mean, just don't know what happens. And I am shocked frequently when one of the things I tend to do is patients who get really sick at our institution, I'll follow up to see if they filled their scripts through our pharmacy thing. And We got a mom who had an ejection fraction of 25%, and she's on 3 blood pressure medications and diabetic. And I sent a note to our nurses, please call the patient, double check she filled her scripts, call the pharmacy, make sure she filled her scripts. And 4 days later, she still hadn't filled her scripts after she'd gone home. And so it's a battle.
Mhm.
But that one falling out, that one doesn't bother me as much as one who was normal intensive for whole pregnancy, comes in at 36.5 weeks and she's 180 over 110 and
We're good at treating those. I think.
goes 12 hours with no treatment. Like that one bothers me. The one you're talking about, that is just to me, that's a clinical judgment for providers in the moment. I wouldn't call that a fallout, I guess. Because that's as much probably patient compliance as it is a hypertension management issue. He looks adorable, but it turns out African wild dogs are the best killers in the savannah. Just a quick heads up.
I thought mosquitoes were.
So, huh?
I thought mosquitoes were.
Right. Yeah, they do get the record. No, so these guys hunt in packs of like 12. This guy, his face is a little bit red because they had just killed an impala. But there was 12 to 15 of them walking around after they just finished their hunt, all with full bellies, like sleeping in the grass. But it was really neat to learn about all the animals on our safari. And there are lots of other animals that follow them everywhere they go because they are so good at killing animals. And they usually take an animal down twice a day to feed their pack. And then what happens is all the other animals, the lions and hyenas and stuff, will come in and chase them off to take their kills because they all know they're so good. So every time we saw these guys, we usually would drive a little bit further and find hyena, and then drive a little bit further and find lions or some other predator that follow these little 60-pound dogs around. It was just wild. All right, so postpartum management. So we published a little paper here a few years ago on medical management of hypertension risks of readmission. And then this was the paper that scooped us on labetalol versus nifedipine. They looked at hospital data, just at ICD-10 codes, and found that patients who were discharged on labetalol with hypertension by ICD-10 code had a higher risk of readmission. Their numbers weren't very big. It was like a 2.5-fold increase or a 3-fold increased risk of readmission. Adverse outcomes during postpartum readmissions. I like to think we had the sentinel paper there at the bottom that talked about readmission based on blood pressure management. And then postpartum management of hypertension effect on readmission rates. That was our second paper that published a few months after that other paper out of New York that showed that nifedipine dramatically lowers your risk of readmission compared to labetalol. So the pilot study we performed at Women's, that was just kind of a collection of observational data, was any woman who had 2 blood pressures greater than 140 over 90 in the medical record. So we didn't look for an ICD-10 code. We didn't wait for a physician to put a diagnosis on the chart. We just looked at pure unadulterated data. And we looked at hypertension at discharge. So within the 12 hours prior to discharge, did they have a systolic or a diastolic elevated blood pressure? And then we looked at which antihypertensives they were on, labetalol, nifedipine, both, none. And this essentially was the chart that was the take home from that and that study. So this chart got broken down to make both studies. Like the one paper we published was that it's better to have a normal blood pressure at discharge. The second paper we published was it's better to be on nifedipine than labetalol. So the crazy thing here is the difference between being hypertensive. So current recommendations from ACOG are labetalol is your first line choice, and it's okay to go home mildly hypertensive. If you do that, your risk of readmission was 13% in our 4,000 patients. However, if you go home on with a normal blood pressure on nifedipine, your risk of readmission is 0.4%. There's a 26-fold difference in the readmission rates between those two management strategies. I would point out that that is the same difference in risk of complication for giving VBACs Cytotec. The risk of uterine rupture with Cytotec is 26-fold higher than the risk for not giving a VBAC Cytotec. So when we all talk about, if someone said, I'm going to give this VBAC Cytotec, we'd all lose our minds. We'd throw you out, have your license pulled, everyone go crazy. Giving a hypertensive labetalol, letting her leave the hospital hypertensive is no different than giving Cytotec to a patient with a uterine scar. And this has been borne out now over our data from the last few years. At this point, we had about a 5% readmission rate we've not enacted any guidelines at women that are formal. Since this is all observational data, we really shouldn't act on it. But what we've found is that just with providers knowing about nifedipine and knowing about kind of what we've learned, our readmission rate has fallen down to about 3% right now. So we've cut our readmission rate about in half. So these are the two papers we published. Like I said, we've dropped that. We're waiting for the acceptance of our RCT data. So this is technically embargoed results. You're not supposed to know about this. I'm not supposed to present or talk about this until it's published. But so we had 3,000 patients that met inclusion criteria during our study. 324 were enrolled, randomly allocated to nifedipine or labetalol. Only differences between the groups was gestational age by a few days and BMI by 1.5, 2 points. There was a higher prevalence of chronic hypertension in the labetalol group, interestingly, even though it was all random assignment. But after we controlled for all of these different things, the incidence of readmission was 88% lower in the nifedipine arm, 1.2% readmission versus 8.1. The adjusted odds ratio, 0.12. So nifedipine was extremely protective compared to labetalol. Frequency of severe hypertension, acute treatment of hypertension during hospitalization, use of magnesium sulfate. Hypertension 12 hours before discharge was similar between both groups. There actually was a trend towards more severe hypertension in the nifedipine group, and there were more severe preeclamptics in the nifedipine arm. So the nifedipine arm was sicker than the labetalol arm, but had a 90% lower readmission rate. And we didn't want to dictate any management in these patients, so we did not dictate that they had to be normotensive at discharge. That was at the providers. This was just managing. All we did for the study was pick your patient gets labetalol to start with or nifedipine to start with. And then this is all based on intention to treat. So if the patient stopped nifedipine, got switched to labetalol, she's in the nifedipine arm. I think we had 2 nifedipine readmissions. One of them did not take her medication. The other came in with 1 severe range blood pressure. And based on our criteria, we strictly included her. 11 out of the 12 labetalol readmissions, I don't think I have that data up there, came in and had elevated LFTs, elevated pro-BNP, severe range hypertension, pulmonary edema, showed signs of essentially heart failure. So the moms who come in with labetalol failure are astronomically sicker than what we're seeing in our nifedipine patients. The nifedipine patients come in with a little bit of hypertension, and a lot of times it's because the ones we've seen come in because they didn't take their meds or they didn't fill their script. Then they come in hypertensive and we treat them and they go home 2 days later and they're fine.
And you said you start all severe hypertensives on nifedipine?
I start all my mild ranges on it too. So all you've got to have is 2 blood pressures, 140/90.
And even during labor?
If they're mild range in labor, I'll start it afterwards, after they deliver. But the data we had showed essentially that if you were hypertensive at any point during your admission, you do better if you go home on blood pressure meds.
So any preeclamptic?
Yep.
Start them on that.
Yep.
You don't wait for like elevated blood pressure postpartum?
Not necessarily. Like if they had a hemorrhage or something and we're worried about them being hypotensive, I'll hold off. But most of them, so the pattern I really see is that day 1 after their epidural spinal for their C-section, their blood pressures, they're in bed caring for their baby, Foley's in place, they're not even getting up to go to the bathroom. Blood pressures look great day 1. Day 2, they get up, start moving around, doing things. Now I see a little bit higher blood pressure, start them on meds. So the C-sections is not as big of an issue because they're usually here through day 2, day 3. So you have time to get stuff going. But my postpartum vaginal delivery is a lot of times the nurse will call and be like, hey, she's 150/90. She's walking out the door. What do you want us to do? And so then we'll just call it script last minute. So a lot of times I'll be pretty aggressive about starting meds in these folks right away after they deliver, even if they're normal intensive, because I know most of them will, 85, 90% of them will be hypertensive before they go home at some point.
So after they deliver, you keep them on the for 24 hours?
For a severe preeclamptic, they all stay on back for 24.
And then do you keep them on bed rest? With Foley's and all the things?
So I believe our nurses are allowed to decide if they think it's safe for the Foley to come out and for the patient to ambulate. Now, nobody's like in the hallway walking. It's like your Foley comes out and you can walk to the bathroom. It's not like you have freedom. But
I'll have to look at our standing orders set just to be sure when we get back. But I think Tanya's question.
I've been in it because
the-
we just did our annual competencies,
Mhm.
covered all sorts of things. But we were looking at like, do we need to do some kind of like SCD, some kind of VTE prophylaxis? Because we do keep ours on bed rest for 24 hours with catheters. Sometimes we'll do a bedside commode. But for the most part, I feel like all of our patients are 24 hours on bed rest with a catheter.
Severe preeclampsia by itself would be criteria for SCD prophylaxis. Because that's a major.
That's not part of our.
It's
that's not
a
part of-
major VTE risk factor by itself.
Not part of our power plans.
Gotcha.
And so that's kind of what I was.
That's why I came up.
That's right, but are you saying even during labor? Or are you
What,
saying
during labor?
the SCDs?
I don't know that we necessarily do it in labor.
If they're on mag and stuff.
I think if they're on mag and they have like an epidural and they're immobile, then we'll do it. But if they're getting up and potentially walking to the bathroom, I think once they reach immobility with severe preeclampsia, if they're in labor, they get STDs or they get pressure stockings. I would say
Is that all based off nurse judgment? Because none of that's in our order set.
the postpartum, I believe the postpartum fully removal and ambulation is at nursing discretion. But my suspicion is most of them are going to stay in bed with a Foley in for that 24-hour period. But I will say all those patients have SCDs on when I come in the next morning. And the trick is all it takes, so C-section, severe preeclampsia, if she's obese, that's criteria for prophylactic Lovenox as well. Postpartum, once you're comfortable starting Lovenox. Now, there's some data out of ACOG recently that we might be over-treating based on the ACS guidelines for VTE because no one's actually studied EVT and VTE in pregnancy. They just lumped them into a high-risk group and they called it unplanned C-sections a high-risk surgery. An unplanned C-section is different than an unplanned appendectomy or an unplanned knee surgery to a degree, because if a mom's labored for 12 hours under your eyes, that's different to me than someone who has a leg fracture from a traumatic MVA. But they've tried to extrapolate pregnancy risk from surgery, from general surgery cases, and it's just a different beast. And essentially what they've done is they've called pregnancy a major risk factor. And then you score based on other things that cause DVT or associated with DVT outside of pregnancy. Because I think growth restrictions might be a minor risk factor. Preeclampsia with or without growth restrictions a major. So the score is all over the place.
I have a question with MAG management
Yeah.
delivery, where I've done it before, like, so say they're on MAG, you have to go for a C-section, we would stop the MAG just because of the risk of uterine atony while you do your surgery and then restart like half hour after surgery. What is your approach with this, or do you do case by case?
I leave it on through. It's that's a provider dependent decision. And there's some observational data that it doesn't affect blood loss in papers where I think they looked at 50 to 100 patients or so. But it's all observational stuff. So I think a lot of those times, those patients, they've been like long labors anyway. So is their atony their MAG? Is their atony related to their extended labor? There's always the question of, is MAG kind of counteracting your PIT or counteracting what you're doing from a labor standpoint? Those are always, we don't have answers to those questions, I guess. That's kind of how I look at it. I generally don't start it. I generally don't stop the MAG. If we have atony after delivery and we're really battling it and we're giving her methotrexate or hemobate or whatever, then sometimes we'll stop the MAG for a little while, but just have to remember to restart it a couple hours later.
You would never treat a severe range pressure and not start MAG, right?
No, there's never a situation where I would not MAG us, unless she had pulmonary edema. Pulmonary edema, like there's a few medical situations where I would hold MAG.
But even with renal failure, you still start MAG and then check levels, right?
I would probably do a 2-gram bolus and recheck a level like in an hour or two to see where her MAG's at, and then bolus her as her MAG level dropped. She's under a lot of stress. She's in a lot of pain. She's having contractions. And that's the thing, is like a lot of times, so this gets back to kind of my QI slide. There are some providers that see when their patients get sick, they feel it as a failure on their part. Like, she got sick. I don't know why they feel like some personal responsibility for it. So if they don't call her severe, she doesn't have to get MAG, she doesn't have to be separated from her baby. Like they see those they don't see managing her that way as keeping her safe. They see it as an indictment of their care somehow, that this mom getting sick, which they had no control over, was somehow their responsibility. And so then what I see is this effort to keep moms with their babies or not to mag mom. And what that ends up doing is putting mom in an unsafe situation. I mean, we've had moms who were 8 hours postpartum. We helped mag because she had pulmonary edema, and the provider sent her down to the NICU for 2 hours to be with her baby. And I'm like, hold on, she's not safe to go down there because she's not on mag. She's not safe to go down there because she's in the first 24 hours after severe preeclampsia with pulmonary edema and severe illness. Like, her seizure risk is even higher than if she'd been on mag right now. She absolutely should not be downstairs. And so, a lot of times the people we work with will treat differently sometimes. And so one of my things is I don't treat the people I know any different than the people I don't. If you're not doing what you would do for a patient who walked in off the street, then you're doing it wrong. Because that's when I see other errors, or I see other complications that could have been avoided, is when we take care of like our own staff. And so I really push for a lot of that treatment. If it's pretty straightforward and standardized, severe hypertension, treat it. Severe hypertension, mag it, 24 hours, go from there. There's studies out there that have shown if you take two groups, people who got magged for 24, people who got magged for less than 24, all the seizures happened in the less than 24-hour mag group.
But you're talking mag for 24 hours after delivery.
After delivery, yep. And I maybe have a patient every year, every other year that I'll mag for more than 24 hours. Who she clearly isn't getting better. We're still acutely treating. Her renal function is still pretty bad. Her liver functions are getting worse, not better. Like, 24 hours to me is not a mandatory off. There's still a critical thinking component to why they're on the mag and what you're treating. And if she's still sick or getting sicker, then she might stay on mag for 36 or 48 hours.
Do you read mag patients when they are readmitted? And is
If they
there
get
a time
readmitted-
frame when you don't read mag them?
If anybody presented in 6 weeks, I would remag them. The thing is though, so out of our data, 90% of patients represent in less than 72 hours. It's rare that you get a mom who's 5 weeks out and shows up preeclamptic. Happens, I've seen it, but it's rare. And that's where so one of the things that came out of our study was recommending that patients be evaluated in the office within 72 hours of discharge. Because 90% of patients were readmitted within 72 hours of discharge. There was a measurable number of patients who were readmitted within 24 that would walk out the door hypertensive on labetalol. They'd be back 24 hours later in pulmonary edema with severe hypertension. Even though they're taking their meds, they're 5 times sicker than when they left 24 hours ago.
What do you do about the ones that are dismissed on Thursday?
Monday morning, first thing. If you had some way to have them come in for a blood pressure check or have them check at home on Sunday and call the on-call doc or come in if their pressures are up. But we don't have a standardized order for patients to get blood pressure cuffs, but it's something I always talk to all the patients about. Grab a blood pressure cuff when we see you in a couple days, bring it in with you. We'll double check your cuff to make sure it's accurate with our pressures here at the office. Check your pressures once or twice a day. Or if you're feeling really bad, you're seeing spots, you have a headache, throw your cuff on, see what your pressures are. Don't check it while you're yelling at your husband or your kids.
And please don't check it 12 times a day.
Right. You have to avoid the obsessive compulsive component as well. Half the patients that our high-risk team takes care of are from Omaha. The other half are from outside of Omaha. So we have to deal with these barriers of access and all that all the time. And so I used to always want, coming out of residency and fellowship, you're an idealist and you're like, well, everyone should get the same care. It's just not realistic. So, if you can get her a cuff out the door and have her call her pressures in or see her local FP, some care and some monitoring for these moms is better than none. And given the risk group that they're in and the impact we can have, I really think our focus for a lot of these moms, the way we take care of them intrapartum needs to persist postpartum for that, especially that first week or two after they deliver. Because that's really where we're seeing mortality in these moms. We're really seeing a lot of sick patients and readmissions. And the one thing I always talk about with nifedipine, because people are like, well, I don't want to start it on somebody who's normotensive. Well, what about that set of twins that came in at 28 weeks who was contracting and we put her on 10 of nifedipine every 4 hours or 20 of nifedipine every 4 hours every day for the next 6 weeks until she delivered. I mean, and she came in and her blood pressure was 90/60, and we didn't blink to give her 180 milligrams or 240 milligrams of nifedipine every day for the next 6 weeks. Nifedipine is a really interesting medication that you don't see hypotension with it. In young, healthy blood vessels, now you get into an older population where they have lead pipe vessels that are lined with calcium. You can get orthostasis and get some symptoms from that, but you really don't see hypotension unless there's 2 agents involved with nifedipine. It gets people down to normal. And I find all the time I'll have patients on 60 milligrams. I'll have them reduce to 30 and check their blood pressures at home, and their blood pressures will be the same. I'll be like, all right, go ahead and stop the 30. And they stop the 30 and they're off all their nifedipine in 2 or 3 days, and their pressures are the same over all 3 days. The nifedipine got down to normal. Their blood pressures came back to normal, but the nifedipine didn't lower them any further. We stopped the nifedipine and their pressures are right where they were.
What about headaches associated with nifedipine? You see a
Oh,
lot of that?
less than I thought we would. So we only had a handful of patients in the study who had to stop for headaches. It's a common complaint. So if they're on 60 a day, I'll split them and do 30 twice a day instead of 60 once a day. I'll have them take it at night before they go to bed, have them take a dose of Tylenol with it before they take it. But it's not uncommon at all that we have to switch over to labetalol. But I try to get them through that first 48 or 72 hours postpartum if I can, because I'm kind of hoping that that's the window that's the most dangerous for labetalol.
Are you saying if you get them through that first 48 to 72 hours, the headaches will go away with the nifedipine?
No, I usually won't. No, but before I switch them to labetalol, I try to talk them through that first 72 hours before I switch them to labetalol. But our theory is that when you look at the physiology of preeclampsia, essentially preeclampsia looks just like acute heart failure. You have increased systemic vascular resistance, you have increased cardiac output, you have all these different measures that look just like acute heart failure. And acute heart failure is the one place beta blockers are contraindicated. And so what I think is that most postpartum women with hypertension are in a compensated heart failure. You're giving them labetalol. You're affecting their ability to, their inotropy as well as their chronotropy of their heart. They can't adapt because you've now beta blocked their heart, and they're flipping into a full-blown heart failure. So that's why they're coming in with pulmonary edema, elevated BNPs, fluid overload, and they look like heart failure. Because as soon as you switch them to nifedipine or acutely treat them, get those pressures down, and they diurese, you see them flip like a light switch, and in 24 hours, they've dropped 8 to 12 liters of fluid, and they're fine. And so I think our theory is that this is essentially preeclampsia is a compensated heart failure in the postpartum period, and labetalol is decompensating these moms.
Are you going so far as to, like, if you had a patient come to you already on labetalol early in pregnancy, being well controlled with that, are you saying, nah, let's try this instead?
I'll ask them if they've been on it before, because a fair number have been on before and they couldn't tolerate it for headaches, and that's why they're on it. If I get to delivery, I'll usually try to switch them at delivery.
Like for their
It's usually when I try
Okay.
to switch them over.
keep what's working for now and then.
Yeah, if it's doing its job, and like I said, the thing is, we don't see women get sick during pregnancy. It's the postpartum period that she's in trouble, and so yeah, I'll try and if she's my patient, I'll try and switch her at delivery. I have a few of them that I talked to early on, like if they're on 100 labetalol BID, something really small, then I'll say, you know what, let's just try this once a day medication. That way you don't have to think about it. You can just put it next to your thyroid pill or your prenatal vitamin and just take it in the morning, and you'll be fine. And so I'll switch them early on if it might make their life easier as well. So the crazy thing about this postpartum stuff is there's a chance we could reduce all-cause maternal mortality in the country by 13%. So we would go from being the worst in the world to on par with France and some of those other countries that are doing 1 or 2% better than we are.
Do they have different?
They have less hypertension than we do.
Also,
They have less chronic disease, less obesity, different diets than we do. And I think all those things weigh in on it. Thank you guys for having me out here. Thanks for everything. This is my passion, obviously. So I think there's a lot of room to make some really big changes in healthcare and especially in women's care. And getting to be on the MMRC, I see a lot of what happens postpartum across the region, and I really see a lot of improvement. And you guys, our hospital, serving as leaders now in the state, I hope we can just keep doing what we're doing.
What do you say about the little Guatemalan women who have a blood pressure of like 90/40 all their life, and now all of a sudden they're 150 or whatever? They haven't met the criteria, but.
For severe, but you know they're sick, right? And that's the hard part. And again, that gets to my point of I treat them very mild. So if she's postpartum and she's got a 141/60, a lot of times I have to convince my partners to let her have 1 high blood pressure before we put her on meds. If I had my way, like, so we did like a cost benefit analysis. If you take every patient who was in our study and put them all on nifedipine postpartum the first day, regardless of their blood pressures, you would save like $250,000 a year on readmissions of complications. And that's just arbitrarily that's taking everybody who has 2 high blood pressures in the computer, regardless of why they had those high blood pressures. Because I get all the time, she was contracting when she came in. And, you know, I see 20-year-olds all the time who come in and deliver a baby and never spike a high blood pressure. So if this little 20-year-old who was screaming bloody murder and everybody in the hospital heard her, if she can deliver a baby and never go over 115/60, that means we need to pay attention to those 140s/90s, even in the patient who's uncomfortable, even in the patient who we think was upset when she had her blood pressure taken or whatever. And at the same time, you know, if you come in and tell a mom she's got a stillbirth, don't put a blood pressure cuff on and take her blood pressure while you're giving her the news. You know, I mean, that's an extreme example, but we have things like that all the time. We'll have a mom who's tearful because she found out she's preeclamptic, and like I'm in the middle of talking to her and I hear the cuff start. And no, I don't want to have to mag you unless I really need to mag you. So, you know, I think injecting some common sense into when you take your blood pressures and how you take them, I think we have a lot of guidelines. We take a lot of thinking out of medicine. I think it needs to stay there. I think even though we have guidelines, you still need to be thinking about each step of your guideline as you implement it and why you're implementing it and what the goal of implementing it is. Because you're going to have situations like your patient who didn't take her meds and came in severe that you need to be able to adapt to. Because we're not going to have, guidelines are meant to cover 85% of your patients, which means 15% of the time you're going to have to think about what you're doing. And if your guidelines are only covering half your patients, you got to ask yourself if we need to have that guideline in place.
You're using nifedipine for preterm labor?
Yeah, we still use it from time to time.
Does it work?
Does it keep them from delivering, or does it work? Does it reduce phone calls?
Oh, it's keeping from delivery.
I mean, that's what the data says. It doesn't prevent it. It doesn't change any deliveries. It just changes the number of phone calls you get. It reduces maternal complaints. Once the like oxytocin receptor antibody didn't work, I think that was kind of like, for me, it was like, we're just not going to find a cure for preterm labor. We're just, it's not meant to be stopped. But we see moms who are really crampy and kind of irritable, especially with multiples. So my personal thought is that when those babies go through their growth spurts, like every 2 or 3 weeks, moms get more irritable because their uterus grows really quickly. Those are when they come in that's when they come in for their preterm contractions, or maybe they change their cervix a little bit. But I feel like if you can get them through those 5 or 6 days every growth spurt, you can buy 2 or 3 week blocks in them. So when I have those moms who come in who've been fine for 2 or 3 weeks, and all of a sudden they have 2 or 3 days where they're really irritable, I'll put them on some nifedipine for a couple days and tell them to take it easy. And then if things pass, you know, you can scale back your nifedipine. When I start, I usually do 30 BID. And then I really only have 2 doses for nifedipine.
Thanks so much.
Yeah, it's good to see you.
And you don't use long acting?
Well, for acute treatment hypertension, I use the short acting.
Right.
For postpartum, I use all long acting. It's all the extended release. So
what about the one that you're trying to prevent phone calls?
Oh, for contractions? Yeah, we use the rapid acting for that actually. Yeah. I have a few partners who will use the long acting. I don't know if there's any difference between the two, but when I was trained, we always used the rapid acting.
Thank you.
Yeah, thank you.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.